Good afternoon, everyone. My name is Dr. Trish Suplee, Director of Professional Education and Research for the Central Jersey Family Health Consortium. I would like to welcome you to our series of webinars focusing on Maternal Health Awareness Week in New Jersey. This presentation is one of 4 being sponsored by CJFHC. Today's presentation will be Myths versus Reality, the truths behind perinatal anxiety and depression. Kathy Donaldson is licensed in New Jersey as an advanced practice nurse. She has practiced in multiple inpatient and outpatient perinatal settings until joining the Perinatal Mood Disorders Initiative at Central Jersey Family Health Consortium in 2018. She is currently the program coordinator. She is an expert in high-risk pregnancy and perinatal bereavement, having cared for her first bereaved mother on her first day as a nurse in 1984. Kathy currently serves on 2 certification exam development committees for the National Certification Corporation, one for perinatal quality and safety, and the other for inpatient antepartum care. She was the principal investigator on studies involving estimation of obstetric blood loss and lateral violence and its effects on perinatal nurses. She has presented nationally on high-risk pregnancy topics and perinatal bereavement, and most recently presented at the 2020 AWON Convention on mental illness among nurses and other associated stigma. She has served as faculty for the Resolve Through Sharing perinatal bereavement training approximately 15 times. Kathy holds certifications as a women's health nurse practitioner and inpatient obstetrics, perinatal loss care, and electronic fetal monitoring. It is with great respect and pride that I introduce to you Kathy Donaldson.
Hi, everyone. Thank you for attending. I wanted to just start out, if you've heard me speak before, you've heard this spiel before, so you don't need to pay attention for the next 15 seconds. I wanted to let everybody know that I have a neurologic voice disorder. So at times my voice will fluctuate probably. It might sound hoarse, it might skip, and that's something that I can't control. So I hope that won't be too bothersome for you. And now let's get started. Okay. Oh, there. Daisy, my slides aren't advancing. Oh, there we go. Sorry about that. Okay, so our learning objectives today are to list 2 causes of postpartum depression and to state the postpartum depression prevalence statistics for both birthing people and for fathers. I really like this quote because it's something that we can all relate to. Postpartum depression is when a bad day comes to your house and never leaves. We've certainly all had bad days, and we can relate to, how bad depression must feel when that bad day never leaves. So some history in New Jersey. Some of you may have been around as long as I have, but for those of you who are newer to practice, I wanted to go back and say that in 2005, with legislation pending regarding postpartum depression education and screening, the Department of Health began a speakers bureau and educated interested professionals. I was one of them to be part of the speakers bureau to provide education to providers throughout the state on screening and about postpartum depression. In 2006, that legislation was passed, and you may recall that it was acting Governor Cody who spearheaded that legislation based on the experience that his wife had and his family had when his wife had postpartum depression. In 2007, that legislation was enacted, and also in 2007, the Speak Up When You're Down helpline began, and the Department of Health published educational brochures. And then in 2007, the Perinatal Mood Disorders Initiative grants were established. And there are, as you may know, 3 consortia. Each of the consortia has one of those grants. You may recognize the brochures that are published by the Department of Health and distributed by Central Jersey Family Health Consortium have this overall design on them. Not exactly like this, but this is the theme. So the legislation mandates that the mother and the family, as available, receive education about postpartum depression during pregnancy and prior to discharge from the birthing facility. And as available, we all know that sometimes, especially during COVID, women end up going to their prenatal visits by themselves. But if they have a partner or a family member or friend who accompanies them, then those people should also be included in the education. The legislation also mandates that birthing people are screened for postpartum depression prior to discharge from the birthing facility and at the first few postnatal visits. Now, back in 2006 and 2007, when this legislation was brand new, most women didn't have a few postnatal visits. We're fortunate now that we recognize that there are risks during the postpartum period, and most women are now having at least 2, sometimes 3 postnatal visits where they can be screened. Most places in the state of New Jersey are using the Edinburgh Postnatal Depression Scale, and that is the correct pronunciation of Edinburgh. It's from Scotland. And perinatal losses, there was nothing in the legislation that mandated or excluded birthing people who had perinatal loss. Some facilities do screen for postpartum depression for losses, and others do not. There's really no right or wrong way to go. Technically, the Edinburgh could be used for perinatal losses because the screen looks at how the woman has been feeling for the last 7 days. So that would probably be prior to when she had her loss. So it is validated for loss, but it's not always used. So why is this legislation important? Well, the number one reason is that birthing people and their families are suffering. There's a lot of pain around depression and anxiety, and we want to try to mitigate that pain. Another reason is that psychiatric issues are the number 3 reason for readmission post-birth. And the average time for admission for psychiatric issues is postpartum day 9. Now, I didn't want to leave this incomplete. I wanted to tell you that the number 1 reason is infection, and the mean admission day is postpartum day 5. And the second most popular reason for postpartum admission is hypertension, and that's on day 3. Psychiatric illness is a preventable cause of maternal mortality. You should know that suicide is increasing as a cause of pregnancy-associated mortality or maternal mortality. I was part of the maternal mortality review team for the state of New Jersey for several years prior to coming into my current position. And it's really alarming how many more suicides there were through the years that I served on the committee. And this is really a national epidemic of sorts. We really need to pay attention to it because suicide is preventable. Part of that is our responsibility to allow women and birthing people. You'll hear me use those terms interchangeably. I'm still working on, technically, we should be referring to people who give birth as birthing people to be inclusive. I'm still trying to work on that as my automatic phrase, so I apologize for using birthing people and women interchangeably. But we really need to look at suicide as a preventable cause by allowing people to talk about how they're feeling. So why don't parents report symptoms? And you'll notice I said parents because we're going to talk about fathers and mothers and perinatal mood disorders. So there's denial. There's nothing wrong with me. This is normal. I'm fine. I'm going to get over this. If I tell anybody how badly I'm feeling, they're going to take my baby away. There is that misconception with DCP&P that they're there to take babies from families, and that's not their aim at all. People sometimes are just too busy. They're living their lives. They're taking care of their families, cooking dinner, working, doing now virtual school. it's very busy. And so sometimes the parent is the lowest on the totem pole. Well, maybe the feelings will go away. That's a possibility. You can certainly hope for that, but that's not generally what happens. Depressed people often lack motivation. It's hard when you don't want to get out of bed to have a list of providers to call to see if they accept your insurance or to make an appointment, or even to call the Speak Up When You're Down line that we'll talk about later. When you don't want to get out of bed, when you don't want to eat, take a shower, do anything. And then there's the shame and stigma. There is still, it shocks me that in 2021, we still have shame and stigma around mental illness. We should be looking at mental illness just like we do diabetes or hypertension or any other medical illness. Mental illness is a medical condition that deserves and requires treatment. So let's get into the myths. Myth number one, anxiety and depression are all in your head. Absolutely not true. These are some of the causes of depression and anxiety. You've heard of chemical changes. It's a chemical imbalance that causes disturbances in mood regulation by the brain. There's genetic vulnerability. If you have an immediate family member or a close family member who has depression or anxiety, you're much more predisposed to suffer as well. Stressful life events. Certain medications will predispose people to depression and anxiety. And just like with any medication, it's really a risk-benefit decision. Is the benefit of taking the medication for whatever the condition is worth the risk of having the depression or anxiety? It's an individual case-by-case decision. Then there are medical conditions that are associated with depression. The one that comes to my mind is multiple sclerosis. Also, and this is not for our population, but dementia, Alzheimer's also is associated with depression. And then there are hormonal changes, and I put them in hormonal changes in brackets because not everyone agrees with hormonal changes being a cause of depression and anxiety. We certainly see it in the perinatal population. We also see it in men during the perinatal period, and I'll talk about that again in a few minutes. Myth number two, perinatal mood disorders only affect women. Well, history was wrong, and I just learned this a few months ago from a speaker, a male speaker who was talking about fathers and postpartum depression. And he said the word hysteria, which is how depression and anxiety used to be referred to, the root is from hystera, the Greek word for uterus. So hysteria really is associated with women and perinatal mood disorders or any kind of mood disorder. So history was wrong again. And this is something that I remember from doing the presentations as part of the Speakers Bureau 15 years ago, that in 18th century France, there was a phrase, I believe it was called folie nerveuse. I tried to look that up, and obviously I'm not spelling it correctly because I couldn't find it, but it basically means crazy in the head. And crazy in the head was one of the only legitimate ways that a husband could divorce his wife in the 18th century in France. Myth number three, perinatal anxiety and depression are rare. They're more common than breast cancer. Think about that. Think of how often we hear about how prevalent breast cancer is in our population. About 19% of birthing people have symptoms of depression, such as sadness, appetite changes, sleep disturbances, etc. About 1 in 7 birthing people, which is about 14%, and about 10% of fathers are actually diagnosed with depression. And you will recall, I'm sure, that the breast cancer statistics are about 1 in 8 people, women, during the course of their lifetime, or about 12% will have breast cancer. Perinatal mood disorders peak in the 3rd month postpartum, in about 13% of women. And in the 4th to 7th month postpartum, about 10.5% of birthing people will have a perinatal mood disorder. Myth number 4, only white, middle, and upper class women have perinatal anxiety or depression. The truth is that all birthing people and fathers are at risk, no matter where they live, what ethnicity they're from, what race they are, religion, etc. Everyone is at risk. So history tells us, as I said in the myth, that this is a Western phenomenon, that white, middle, and upper class women have perinatal mood disorders. But you know what research found out about within the last 20, 25 years is that we didn't know about those other women having perinatal mood disorders and fathers because no one asked them. Most of the research was done with middle and upper class white women in Western society. So remember, history was wrong. We're rewriting history even as we speak. And if you are a parent who is from a culture where mental illness is not accepted or discussed, you may even be at higher risk to develop a perinatal mood disorder because you're not allowed to say anything. There's such stigma associated with it. Recently, there was a discussion with one of my colleagues and someone from another culture, and it was suggested that there be some perinatal mood disorder education for people from this particular culture. And the person said, no, we don't have that. Of course they have it. It's not talked about. There are people who are at higher risk. Adolescents are at a significantly higher risk. Think of all the changes that adolescents are going through. Well, there is a term coined, I believe, by Karen Kleiman, who's a well-known researcher and author on perinatal mood disorders. And she talks about matrescence, or the birth of a mother, and how difficult that is. Imagine being an adolescent and trying to be a mother, figuring out who you are as a person and trying to figure out yourself as a mother. Low-income women are at higher risk. And then single women without a partner living in the same home are also at risk. I thought this was really important because if the partner, and it could be the father of the baby, it could be another partner, if that person does not live in the home, they're not immediately available to the birthing person or the mother to help or to provide support. Even if they're 5 minutes away, that still puts the mother at risk. Myth number 5 is only people with mental health histories, perinatal anxiety or depression. Well, remember what I said a few minutes ago. Everyone's at risk. It doesn't matter if you have a history. And this was one of the things when I was a nurse at the bedside. People would come in and say, well, nobody in my family has blood pressure problems, or nobody in my family has X, Y, and Z. And I would always say, family history has to start with someone. It has to begin somewhere. You might be the first in your family to have hypertension or a particular complication of pregnancy. You might be the first person in your family to have a mood disorder. Myth number 6, depression during pregnancy isn't a big deal. Here's a list of potential effects of untreated depression if it occurs during pregnancy. Women who are depressed, birthing people who are depressed, don't take care of themselves as well as if they weren't depressed. They don't eat as well. They don't get prenatal care as routinely as they would perhaps if they didn't have a mood disorder. There are negative effects on bonding with the pregnancy. There is a higher incidence of substance use. There is an increased risk of pregnancy complications, and that is linked to the fact that birthing people tend to be non-compliant with prenatal care if they have a mood disorder. Postpartum depression as a complication of the postpartum period is a risk, as a complication rather. Some women terminate pregnancy because emotionally they just can't take it. They're just so depressed they can't imagine continuing a pregnancy. And then, of course, there's suicide and infanticide. When you hear about suicide and mainly infanticide, I'll correct myself. When you hear about that in the news, like I remember Andrea Gates in the early 2000s, who drowned her 5 children. It was all over the news that she had postpartum depression. Well, you know, she probably did, but she didn't kill her children because of postpartum depression. She had postpartum psychosis, which is a totally different animal, and it's a medical emergency. The women, if they talk about having symptoms or fears of postpartum depression, they think of those news stories and think, well, I don't want anyone to think that I'm going to kill my children or harm my children. The scary thing is that we really don't know all of the effects on fetal development at this point. So I'm sure we will continue to uncover some of those things, some of those effects as the years go on, but we really don't know. I can remember, you know, when even in my mid-career, and I've been a nurse for almost 37 years, I can remember we didn't think stress had any effect on pregnancy. And now, of course, we know that's wrong. So we're finding more and more about mood disorders and their effect on pregnancy every day. So risk are contributing factors for birthing people: low self-esteem, poor sleep quality. I say this to the moms that I talk with all the time, that for me, when they're feeling bad, you know, I relate it to myself. If I don't sleep well, I don't cope with anything well. I don't work as hard. I don't do things around the house as much if my sleep isn't good. So think of what a new mother's sleep is like, or a new father. Women with very stressful life events. A history of childhood sexual abuse. I read an article many years ago that it takes someone who was sexually abused as a child 6 times longer to have resolution of symptoms of depression than it does someone who didn't have childhood sexual abuse. Adolescent pregnancy. Hormonal shifts. And the hormonal shifts are particularly problematic during the first 6 weeks after birth, and again during weaning, if the woman is breastfeeding or the birthing person is breastfeeding. They are all what I refer to, frankly, as hormone hell. If someone has had a difficult pregnancy or a traumatic birth, they're at more risk. And here's the surprise. There are clinical definitions for traumatic birth, and we all have ideas about what a difficult pregnancy could be like. But the bottom line is the determination of whether the pregnancy was difficult or the birth was traumatic lies with the person who gave birth or was present during the birth. So it's not up to a clinical provider to determine this. And then, of course, pregnancy loss and infant death. There's confusion that grief and depression are the same thing, and they're really not. They're 2 distinct conditions. Grief can certainly lead to depression, and depression can worsen grief, but they are different. And then I just read this article yesterday that polycystic ovarian syndrome, or PCOS, is associated with the higher risk of depression. It was a study that included 3,900 women with PCOS, and they followed them through pregnancy, and I believe for a year postpartum, and approximately 19% of them were diagnosed with clinical depression during that postpartum period. So what are the risks or contributing factors for fathers? A history of mental illness. Did you know that men go through hormonal changes in the postpartum period, just like women do? I didn't know that until I started reading about it. In the perinatal period, it's very common for men to have low testosterone levels. And that's not fully understood. But certainly, if you have hormonal changes, you have a mood disorder, could predispose you to a mood disorder. Lack of social support. Think about the men in your lives. Do they have a lot of social support when compared to women? Women are much more likely to have friends and talk about their feelings and what's going on in their lives than men are. Men typically, and of course this is, I'll stereotype a little bit, but it's pretty common across cultures that men are socialized to be the strong ones, to take care of their families. Well, what happens if the father doesn't feel like himself and isn't up to taking care of the family and going to work every day and doing all the things that are expected of him rather? Can he pick up the phone and call a friend or a family member and tell somebody else how he's feeling? And then a partner with anxiety or depression puts fathers at risk. So what do you think is the number one risk factor for perinatal depression in fathers? Look at that brief list of 4 things. The number one risk factor, if the father has a partner who has anxiety or depression. Now imagine what that household would be like. The birthing person or the mother has anxiety or depression. The father also has a perinatal mood disorder. Imagine how disruptive and disrupted that household would be. Myth number 7, depression and parenting are separate struggles. Depression clearly affects a parent's ability to parent, whether it's a birthing person or a father. Parents who are depressed are much more likely to feel overwhelmed and incompetent. My colleagues and I hear frequently from the mothers that we speak with, I'm so overwhelmed. I didn't expect it to be like this. I'm not a good mom. I'm not a good mom because of X, Y, and Z. There is an excellent book, and I pulled it up on my phone. The author is Ginger Breedlove. She's a nurse midwife, and she published a book called Nobody Told Me About That, the First 6 Weeks. And it's a really frank account of what the first 6 weeks of parenting is like. Parenting styles with a mood disorder may be withdrawn or even hostile, and they can fluctuate. They can be very labile and change from day to day. Parents who have depression are less likely to have a daily routine or engage in positive activities such as reading or playing with their child. When you don't feel like getting out of bed, you're not going to feel like reading, listening to music, playing with your child, cooking, having a daily routine. This is a video. It's about a 2-minute video, and I'm going to just pray for a minute that it works. It's called the still face experience, and it simulates the effects of depression on a baby. Let's watch. So this is Dr. Tronick. He's a researcher. He's been researching the effects of depression on babies for about 40 years at the point where this video was. And this video is about 15 years old. And he did an experiment called the Still Faces experiment. And you see this mother interacting with her baby who's about a year old, and she's talking to her, and the baby is interacting. The baby, you can see the baby's trying to talk. She's pointing at things. The mother's turning around. She's looking, but they're interacting. And in a second, you'll see baby's laughing. She's happy. She's happy to have that attention from her mother. Now the mother turns her head and simulates a depressed mother with no facial expression. And look what happens to the baby. The mother no longer responds to the baby at all. And this is what happens very often in depression. What you can't hear is that the baby is screeching. Look, she's pointing. She knows that usually when she points, the mother responds by looking in the direction that she's pointing in. She's reaching out to her mother, begging her for attention. And eventually she starts to cry and hiss and, make noise trying to get her mother's attention. I think it's a very sad thing to watch, but the baby clearly is distressed. So the good thing about this is that in a few seconds, you'll see that the mother goes back to being her normal self and being responsive to the baby. And you'll see the baby immediately responds and calms down. I'm sorry you couldn't hear the narrative on that. It didn't work when we tested it today. But depressed parents, think of how babies make facial expressions, that they make sounds. How do they learn to do that? They mimic us, right? So if you have a depressed parent who's not engaging with the baby, not having varied facial expression, not talking to the baby, interacting with the baby, what's ultimately going to happen is the baby is going to become somewhat apathetic and learn that mommy or daddy is not going to pay any attention to me. Mommy or daddy is not going to engage with me, so why try anymore? So that's how we see mood disorders impacting infants. Myth number 8, depressed people are always sad. Well, here are some symptoms of depression and anxiety, and sadness is there, but depression can be a collection of symptoms that include sadness, but the sadness may not be always persistent. There can be worrying, excessive worrying about everything, feeling restless or on edge all the time, muscle tension. Do you keep fists? I remember I was a very intense, I still am pretty intense person. And I can remember sitting in the car with my mom, and my mom would be driving and I would have my fists clenched, and she would put her hand on mine and say, Kathy, relax your fists, relax your hands. But that was the tension that I had. Feelings of worthlessness, excessive guilt. And we're talking about guilt about things that most people would never feel guilty about. Withdrawal and isolation from family and friends. Now that isolation has a whole new definition in a pandemic. But back when we weren't so isolated, people with depression or anxiety would deliberately isolate and not interact with their family and friends because they didn't feel like it. They just don't feel like it. Or they're afraid that somebody will find them out and will see how badly they're feeling. And that may not be a good thing necessarily in the depressed or anxious person's mind. Some people have reckless behavior. I had somebody tell me a couple of weeks ago that she has visions of herself driving off a bridge. And she finds herself driving faster than she probably should, thinking maybe somebody will hit me with a car and kill me and put me out of my misery. Fatigue is a major symptom of depression in particular. Changes in sleep patterns, that can either be insomnia or hypersomnia, not enough sleep or too much sleep. Changes in appetite, weight gain or weight loss, could be either. Anger or irritability, physical pain. Many depressed people in particular have physical pain and may go to their providers complaining of pain, and nothing's diagnosed, and it may be completely related to their depression. Many anxious people, as you know, will have chest pain, and shortness of breath. And yet when they're evaluated, if they're evaluated, nothing is found. Problems concentrating, there's that persistent sadness, and then suicidal or homicidal ideation, of course, is a red flag. The other thing that's true for perinatal mood and anxiety disorders, that's what PMAD stands for, is something called intrusive thoughts or compulsive thoughts. So what are intrusive thoughts? I loved this definition that I found online. An intrusive thought is a stuck thought that causes a lot of distress. Think of when you get a song in your mind and you can't get that song out of your head, and it's with you for hours, sometimes all day. Well, think of what a negative thought would be like, what it would be like to have that all day or all night. Intrusive thoughts come out of nowhere and they arrive with a whoosh. And I think I just love that description, which is why I included it. It's sweet. An intrusive thought sweeps in and tries to take over. They often focus on things that are socially unacceptable, like sexual thoughts, religious thoughts, violent thoughts, or very explicit thoughts that the person would never normally have. But with a mood disorder, they may have these intrusive thoughts. We all have intrusive thoughts from time to time, but when you have a mood disorder, intrusive thoughts can be persistent and very extremely disturbing. And when I say that we all have them from time to time, I'm guessing that those of you who are parents have thought, oh my gosh, what happens if I fall down the steps with the baby? Or what happens if I trip while I'm holding the baby? Or something, along those lines. Thinking what happens if something happens to the baby. Intrusive thoughts also bring on safety concerns. So they basically bring on fear. But the good news about intrusive thoughts, and this is a way to reassure parents, is that thoughts are not actions. Our thoughts don't have the power to make things happen, no matter how strong they are. They're powerless. The experts say, don't try to figure out the thoughts. Try not to, as much as you can, try not to focus on the thoughts. Don't try to analyze why you're having the thoughts. Allow those thoughts and any anxiety that those thoughts bring to you, try to let them pass through. Mindfulness is a huge buzzword now. Talks about quieting the mind. Mindfulness is really about being in the present and letting your thoughts just kind of, almost I think of it as in one ear and out the other, in one side of the brain and out the other. This is an excellent book by Karen Kleiman, who I mentioned earlier, and I'm going to show you a few images from it. It's called Good Moms Have Scary Thoughts. What if I don't have enough love left for a new baby? I feel so guilty. I feel so sad, like I'm losing time with my son. What if he doesn't forgive me? What if I made a mistake? I'm so nauseous. I've pooped 6 times this morning. Hemorrhoids are going to kill me. Torn, swollen vagina and stitches. Seriously? Oh my God, my hair is falling out. I hate my husband. My boobs are rock hard. My clothes don't fit. I just peed myself. If anyone touches me, I will scream. And yet if somebody asks her, she might just say, I'm having a really bad day, when in truth, all of those things are running through her head. If I admit I don't feel like being a mother and that this sucks a lot of the time, does that mean I don't love my baby? I have to check the baby. I have to check the baby. Are you breathing? You're not breathing. I just checked. I don't see your chest going up and down. Oh my God, you're not breathing. Oh, wait. I see your little chest rising. You are breathing. I'll just stay here. The best thing I can do is just watch you all night and make sure you're okay in case you forget to breathe. I'm going to go back to that. I've spoken to mothers and heard stories of mothers where they and their partners take shifts, 12 hours for one, 12 hours for the other, and somebody literally watches the baby to make sure the baby is breathing. Not a good thing. Myth number 9 is once depressed, always depressed. We're going to talk about some non-pharmacologic treatment options. I did not include medications because that could be an entire webinar on its own. So we'll talk about some non-pharmacologic treatment options. And the first step towards getting somewhere is to decide that you are not going to stay where you are. Asking for help is sometimes the hardest thing to do, but that's the first step. Postpartum Support International, and that website is postpartum.net, says that PMADs are temporary and they're treatable. And that's so encouraging. Again, I speak mainly with mothers and birthing people. It's so encouraging for them to hear that this is not going to be their life for the rest of their life. This can be changed. Myth number 10, all you have to do is ask for help. That's sometimes the hardest thing. Here are some of the barriers to getting help. I can do this on my own. We like to think that we can fix anything on our own without help, right? If I tell my doctor, my midwife, my therapist, my friend, I won't be taken seriously. How many times have you heard, or maybe you've said, I know I have, well, of course you're a new mother. Of course you're anxious. Of course this, of course that. That's not validating what someone's telling you. There's an aversion to the medical model for some people, and we've heard a lot about it with the COVID vaccine, and I won't be able to make my own decisions regarding treatment. There's mistrust and distrust in some cultures, the medical model, because of history and what's happened historically. In our today's society, in our country, people are able to make their own decisions. And then we're back to stigma and shame. And the way that I think of stigma and shame as it relates to mental illness is like handcuffs. You're stuck, you can't move, your hands are bound, and we do everything with our hands, right? If they're bound by handcuffs, you can't do anything, you can't seek help, you can't want help, you can't do it. So some self-help things that may benefit are rest. How many times have you heard, or maybe you've said, sleep when the baby sleeps? So what happens if the mother or the father can't sleep when the baby sleeps? Then they get upset. I'm not doing it right. I should be able to sleep. So what I've changed my advice to be is rest when the baby's sleeping. And rest could be getting outside, could be listening to music, could be reading a book, could be just doing anything that you enjoy. I've noticed a lot for myself, particularly in the beginning of the pandemic, that being stuck inside was really tremendously affected my mental health. So even if I got outside for 5 minutes and smelled the fresh air, I felt a lot better. If you're able to, take a walk with the baby. Of course, always the recommendation is to eat healthy foods, stay hydrated, and avoid alcohol and other substances. They may temporarily improve your mood, but they don't help in the long run, as you know. Set realistic expectations. You can't possibly do everything with a new baby that you used to do when you didn't have this baby to take care of. Try to ask for and accept help. Sometimes accepting help is just as hard as asking for it. Scale back your expectations to have a perfect household, and it's okay to hang out in your sweats. And I love this quote: "A messy house is a sign of a happy family, and yet there's so much guilt around the fact that the parent can't vacuum or can't clean the kitchen or can't doesn't do the laundry as quickly. All of those things, all of those expectations, they're no longer realistic, possibly with a new baby. Avoiding isolation is huge. And as you can imagine, that was a huge source of anxiety and still is because of the pandemic. It's important to be honest with your partner, with your family and friends about how you're feeling. I don't know if you remember the public service announcements that New Jersey had a few years ago, where a coworker would come up to a father and say, "How's Susie doing? Congratulations, how's Susie doing?" And he'd get this bubble where Susie was crying all the time, or she was yelling, or she wasn't eating, all of these negative things that indicated that she had depression. But what he'd say is, "Oh, she's doing fine." Why can't we talk about it? We talk about blood sugars, we talk about blood pressures. Why can't we talk about mental illness? Talk with other new parents about their experiences. A great way to do that is to go to a new mothers or a new fathers group. We offer both of them at the consortium. I'll tell you more about that and how to get that information shortly. And ask your local healthcare provider about support groups. The consortium is a great source. We know all of the, well, we think we know all of the new parent support groups in our region. And we actually have a brochure. All of those support groups are virtual right now, and we'll be happy to share that with you if you'd like. Support groups are evidence-based treatment for perinatal mood and anxiety disorders. As I said, we offer new mothers groups. We offer 2 English new mothers groups on Tuesdays and Thursdays at 1 o'clock. We also offer a Spanish group at 1 o'clock on Wednesday. And then we offer a new fathers group. All of these were started in the spring with the pandemic because of a lot of the support groups that the hospitals ran weren't fully functioning in the virtual environment yet. But we're the only place in our region, as a matter of fact, in most of the state, that has a support group for new fathers. Now, I haven't attended the new mothers group. I have attended the new fathers group when they've had special events. And this group is absolutely wonderful. Men, they share their raw emotions with each other and they support each other, and because they know it's a safe environment to do that, and it's great. So if you're interested in learning about our support groups, Pat Venna, who's one of my colleagues, facilitates all of the English mothers groups and the fathers group, and you can email her for more information. We're also fortunate to have another facilitator for the fathers group, Jim Doherty, who is a pediatric registered nurse, retired, and he was a stay-at-home dad with his twin daughters for the first 7 years of their life. So he can completely relate to what it's like, to what the stress of being a new father is like. And even though his daughters, I believe, are 24 now, he's able to relate to what the new fathers are telling him in that support group very, very well. And he's really great. So treatment helps to mitigate symptoms. It may allow the person to care better for himself, herself, and the new baby. The phone follow-up program at Central Jersey Family Health Consortium is what I coordinate right now. The consortium, our consortium, serves Hunterdon, Somerset, Ocean, Middlesex, Monmouth, and Mercer counties. The telephone number that you see there, extension 179, is my office extension, but right now you'll only get voicemail. The voicemail will come through to my email, so I will get it very soon after you leave the voicemail. The 2 better ways to try to reach me, if you have a mother who needs support or you want more information, is to either text me, and that's the number, that's a text-only number, or you can email me, and I will respond to you as quickly as I can. Our primary goal is to connect at-risk birthing people with support, treatment resources, and other community resources. We follow the birthing people who are referred to our program for about 3 months. And the key is that they must consent to the referral. So there's actually a referral form that the provider or the birthing hospital completes and either gets the mother's verbal consent or written consent, and they send that form to us. We also accept phone referrals. We also accept self-referrals for mothers who hear about our program who'd like support. We want to support as many people as we possibly can. And last year we had about 2,500 people referred to our program. There is also a service called Speak Up When You're Down. It's a toll-free number through the Department of Health. It's called the New Jersey Family Health Line. So when a person calls that number, it will say, you've reached the Family Health Line, and then there's an option for postpartum depression. This is a service for uninsured mothers or mothers who have Medicaid, birthing people with Medicaid. And it allows for evaluation and treatment, including up to 12 free counseling sessions. That's a 24/7 number, by the way, so they can call anytime. All the written brochures that are either published by the Department of Health or by our consortium, and we have several, can be ordered through Jerry San Antonio at the consortium, and there is his phone number. He can send you an order form or take your order over the telephone and mail them to you. Any materials that Jerry ships are shipped free of charge to you or to your hospital or your agency. These are the other two consortia in the state, and you'll see the counties that they serve. So I'll leave this up for a minute so that you can find the appropriate contact information for your consortium if you're not part of the central consortium. And this webinar is being recorded, so you'll be able to get this information again if you missed it. So these words are from Postpartum Support International, and I think they're so encouraging. You're not alone. You're not to blame. And with help, you will get better. And then I added a fourth statement. Don't tell PSI. There's nothing to be ashamed of. And you can see I have open handcuffs there, because once someone reaches out for help and feels better, it's very, very freeing, just like breaking those handcuffs. I have some resources for you. And I'd like to end by asking if anyone has questions. Thank you so much for participating today.
Thank you so much, Kathy. That was really a well-presented information session on that topic. I'm going to ask everybody to please put the questions that you have in the chat room. But one of the questions that I actually have is, or it's not really a question, it's more of a statement about that video, watching the woman interact with her child. I think it's one of the most powerful videos I've ever seen. And it really puts it in perspective to me with regards to how the woman's health will ultimately affect that infant's health. And I was wondering if you could comment on that.
Well, as I said, children learn how to behave a lot through their parents, and they get their emotional health and their coping skills from their parents. And those kinds of things are learned very early. And you could see in that video how affected that baby was by the mother's seeming change in mood. So I think that's a very powerful video to show. And the research is so valuable, and it's been going on for 40 years.
The next question is, if a woman fills out the Edinburgh scale in the hospital, how would she know she got referred?
Well, you can't refer a mother without her consent. So what I would recommend is if you have somebody who scores high on the Edinburgh, or if she has a history of postpartum depression or anxiety in the past, or depression not associated with the perinatal period, or has any of those risk factors, even if she doesn't score high, what I would do is I would say to her, there's a great program through the local consortium, and they will support you. They will provide phone support or text support for up to 3 months, so that if you develop any concerns about depression or anxiety, they can not only support you, but they can get you help. And that's what we do. But the mother has to consent to that referral.
And how would our clients know about the fathers groups?
It's in our virtual support group guide that we just updated. So I would suggest that if you don't have that, and you probably don't because it is very new, I would order some for your hospital and maybe have them available where you have other brochures available, or give them to new parents so they have that resource. We put the consortium groups right on the first page as soon as you open the trifold brochure so that they stand out. Because like I said, we are the only one with a fathers group.
Okay, great, thank you. Right now, I don't see any other questions. I'd like to thank everyone for coming on today and joining us. And like Kathy said, the video will be available on our site probably sometime next week. You can obviously, share with your colleagues that they can go on. All of these webinars are for free. So again, we're wrapping up our week. We had 4 great presentations that will all be available, again, highlighting maternal health awareness. And I hope you take the time and share your experiences with your colleagues, and hopefully we can also see more people watching those videos and webinars. So again, thank you very much. Thank you, Kathy Donaldson, again, for your expertise. And I wish you all a great weekend. Take care. Bye.